Hey there, good afternoon. Welcome. My name's Caitlin. I wanted to get started here right on time. Hey there. Some of you have been in other trainings with me before. If not, nice to virtually meet you. So we are scheduled to go just until 2 o'clock, just for an hour. We will not go over that time. A few just reminders in terms of housekeeping. If you want a copy of the slide deck, if you click on that little arrow next to handouts on your GoToWebinar interface, you'll see a PDF of the slide deck. You'll also see a PDF there of the webinar tech support. So if you're running into any technical issues on your end, you can download that, and there's some kind of troubleshooting ideas of how to navigate that. So I wanted to make sure that folks knew where to access those handouts. So also during the live presentation, if you have questions for me, please type those into the questions box. So on your interface, again, you'll see a little arrow next to questions, and you can type those in. If you see me glancing over from time to time, it's keeping an eye on those questions as they come through. The way GoToWebinar works is that I will see those questions coming through, but other people won't. Normally I can pretty much get to most questions. If there's a ton of them and I can't get to it, I apologize. I'll answer as many as I can. We will have some time at the end for Q&A. So just wanted to kind of clarify that in terms of the live version. This is also a provider CEU. So the way that we do that through Canopy is that you can either just go to our main Canopy website and click on the providers button at the top, and you'll see a section on CEU webinars. Probably by the end of this week, we'll get the recording of this up on that page, and you can go in and take a quick 3-question quiz about it, and once you pass that quiz, you'll get the certificate. So that is how we offer that CEU credit for the class. If you have questions about your specific board and CEU requirements, I encourage you to talk to your specific certification board about that. Okay, that was a pretty quick housekeeping. So we have almost 100 people in here already. That's wonderful. I do have one live poll question that I'll do in a little bit, and I always love to get participation in that. So let's just jump right into it. Before we get into the content, very briefly, just quick background. So my background is as a clinician. I've worked in the clinical field, mental health field for 15 years. I've worked with individuals, couples, groups, families, and my specialty kind of early on was really around trauma and addiction treatment. I've now moved more into the consultation and training side in terms of my role at Canopy. But one thing that I have found very interesting and that I think is really important as I've learned more about OCD, and sometimes I think there is a lot of misconceptions and a misunderstanding of it. And I thought it was a really good time to give an overview for providers. So just kind of an education around that. But I wanted to give that quick background on my background before we get into the content. Okay, so with that, I promise I'm not going to read the slides. I know everyone here is more than familiar with the DSM, but we are going to be talking about the obsessions and compulsions piece. And as the definition of this webinar talked about, it really is going to focus on what are some of the common myths, misconceptions. What does this look like in real time in session? Because again, I know everyone here can look this up in the DSM, but I wanted there to be a starting point of what we're talking about. So we're all on the same page here. And again, for folks who may have joined a few minutes ago, you can download this whole slide deck under the handouts. So I'm actually going to start with a poll question before we even get into the rest of the content. The way that that's going to work is I'm going to launch this poll. And you should see that on the screen momentarily. And then these poll questions are completely anonymous. No one knows if you answered it, let alone how you answered it. So I definitely would love to, if people are willing to participate in this. I kind of wanted to just see a general overview of the breakdown of the stats for this. And I'll give it a few more moments as people are putting their answers in, and then I'll show everyone the outcome of it. I think it's always helpful to see kind of where we're at. And this training really is meant to be for folks on kind of any experience level. All right, so we had almost 70% of you voted, and there's 85 people here. Oh, we have more people voting. So 70% of you, or a little over 70% voted. There's still some coming in. Oh, we're almost at 80% have voted. All right, so we're gonna close that out and share so you can see here what that looks like. And as you can see, there are answers in all of these categories, and that is great, and that's why we're here. So, you know, all of us, as we all know, in terms of continuing education, can learn more. So it's, again, just thinking, what are ways that I can expand my practice, expand my awareness, and what that looks like for me. Okay, thank you all for participating in that poll. And if there's any issues with like sound, microphone, type that into the questions. I've got a backup mic if needed, but if there's anything, please just type those into the questions box. But certainly that's also for if you have questions about the content. Okay, so as we look at, you know, I kind of want to start the first half, probably at no surprise, of what are we looking at? What are some of the differential diagnoses? And then what can we do? So there are multiple different treatment modalities, of course, but we'll get into those a little later. I do think that this is a very common either misdiagnosis or OCD or OCD tendencies can be missed through the lens of the person is dealing with anxiety. And so wanted to kind of quickly break down how are we looking at and defining generalized anxiety disorder and OCD. So of course, this is, as we all know, with differential diagnosis, there's going to be, of course, a lot of crossover of certain symptomology. It's the patterns, it's the why. And so this is why, and I'll provide plenty of resources in this training of how to assess more effectively, to look for it, but also just from a clinical perspective to have it in the back of your mind. And that's where we'll get into kind of the myths around OCD that even as clinicians we can get caught up in. But with OCD, again, with these obsessions or compulsions, sometimes that can show up as hyper-responsibility, which can come from that needing to always have control over everything, which also leads to a difficulty in delegating tasks. So there's kind of these energies behind some of this obsessive compulsive disorder that's much more specific than that generalized anxiety disorder. And you'll see some of those patterns more in the OCD. So gathering more information from clients is really important because, like I said, sometimes it's just quickly seen as anxiety. And we will spend some time talking about, you know, our tried and true CBT. And the, you know, sometimes challenges of what that looks like in terms of a treatment with OCD specifically. But it can often be utilized to treat anxiety, and then we end up kind of missing the OCD component or not treating that effectively. Okay. So probably most of us know. Also, I'm already realizing that at the beginning of every slide, I kind of like take a breath and say, so I will try to mix that up. What I wanted to do with this is that most of us are aware of how many myths or assumptions are made around something like OCD. Even how often it's used in common language. So it's like, oh, I'm so OCD about cleaning. We hear people say that just casually. And because of that, and I think because of pop culture, movies, TV, all these things, OCD has this very specific kind of concept that people have in their mind when they hear OCD. And clinicians sometimes do as well. And I'm going to talk more a little bit later about covert compulsions, because sometimes with OCD, if it's not the more sort of obvious kind of cliche quintessential OCD symptoms, those are the ones that are so often missed. But the cliche, hand washing symptoms is a very small slice of what OCD symptomology looks like. So some of it is just, of course, educating ourselves, but it's very important for the psychoeducation piece for clients, because most often they're coming with that very, very specific assumption of what OCD is and what it looks like. So dispelling some of these myths. Again, that first bullet point is a very common one. It's like, well, all of us are a little OCD. In terms of a diagnosis, that's not true. So, you know, what it includes, that is not just hand washing or cleanliness. It's not always obvious. It is treatable, and I think that's a common myth that we have to dispel for a lot of mental health symptomology and disorders, certainly not just OCD. I'll talk a little bit later about motivational interviewing as it relates to kind of OCD, sometimes like, but it's helpful. And how can we sort of work with someone in terms of where they're at with either ambivalence or awareness around that symptomology and how that's showing up. But that's a really common experience people may have, that OCD is just someone who's anxious and neurotic. So a lot of these, if you are reading those and thinking, sometimes I make that assumption, or I was already thinking that, or I've heard clients say that. So asking more questions, kind of reminding folks and taking that time to educate clients. If you have questions, please type them into the questions box. We already have almost 100 people in here right now. So I always like to remind people just kind of throughout, if you have a question or comment. Also, if there's something that you have utilized or tried in your clinical practice that's really helped, type it into the questions box and I can share that with folks. So even if it's not technically a question, any kind of shared information is always wonderful. So if anything comes up in terms of something you want to share or contribute, feel free to type that into the questions box. So some of this, again, is continuing to expand our awareness and knowledge around that. So being mindful to not have your kind of OCD assessment be purely just on the obvious compulsion behavior side. A lot of this today is going to be about the kind of less obvious symptoms around OCD that can quickly become, oh, that's just anxiety, or not really noticing those patterns. I'm going to show in a little bit a snippet of an official OCD assessment tool, and it goes into a lot of detail of examples of specific types of obsessive thoughts. And one reason, I think reducing stigma and being aware of our own unconscious biases is important as a clinician, no matter what. So that goes beyond just talking about OCD treatment. But the reason I say this here is that some folks who are struggling with obsessive thoughts, those thoughts might be very distressing to hear. They can be related to violent thoughts, other, again, I'll show a slide of one of the assessment tools that will have more examples. But as a clinician, if we're hearing someone or a client have thoughts like that, we have to be aware of what are my own triggers hearing that, and how can I be aware of those potential triggers and have that unconditional positive regard. I know it's a very clinical term, and see this through the lens of an OCD, potential OCD symptom. And if we get caught up in that either initial judgment, trigger point, bias towards that person, it is going to skew our ability to meet them where they're at in terms of what they need for support. And I think one of the things that can be really challenging with working with folks with OCD is, understandably, in many cases, they are not super comfortable sharing some of the obsessive thoughts they're having. And some of that is also why it's so important to provide psychoeducation to clients. Say it's common, their OCD can include obsessive thoughts, and those can be very distressing thoughts. And reminding them that that is common. In terms of that, being willing to hear their story and in a non-judgmental way, and work with them on a plan of action. So it takes a lot of courage for folks to share what their OCD symptoms are. And it starts with even getting to the point of kind of maybe them realizing that's what's happening. And so really checking in with those steps you're taking as a clinician to, check your own assumptions or biases, provide that normalization of obsessive thoughts often being very distressing for folks, and creating that safety, that psychological safety around that. That's a kind of a unique aspect of that OCD. I think a lot of times people experiencing OCD, and of course we can say this for a lot of different symptomology or diagnoses, is just they're feeling very isolated and having to kind of pretend it's not happening and go about their lives, and that can be very exhausting. And also that can come from feeling like there's no solution to it, there's no treatment. So again, the more conversation you have, the better. So this is also, I'm going to go into a lot more detail later. Again, I keep bringing up CBT, and I have no problem with CBT, but also it's not always the best course of action, certainly not by itself, a lot of times with OCD. But when we're getting caught up in just thinking someone's struggling with anxiety, in some cases we just jump towards straight to kind of CBT interventions, and that is oftentimes not sufficient in terms of OCD treatment. So that's where I will share here in a moment some of those assessment strategies and tools to use to gather more information about what's going on. And I know this was also in the overview of the training, is how do I see this more holistically of the approach to treatment and assessment. Okay, with this aspect, because I think, again, when they are kind of more of those classic, what we all kind of see as not standard, but common, or I'm using the language I don't want to be using, the myth of everyone just hand washing all the time or having to turn the light on 3 times. Sometimes as a clinician, if that's not happening, we're missing some of the symptoms. So I wanted to provide some examples. This is not a complete list, but some common examples of covert compulsions. And one can be that avoidant. So that can come up as avoiding certain tasks, going to the grocery store, some type of common task we have to do to prevent that onset of intrusive thoughts. So for example, maybe someone has some obsessive thoughts of like fear of germ contamination, so may avoid certain places that they feel like that intrusive thought is going to be triggered. And again, sometimes we see that as, oh, that person is anxious or has social anxiety. And I'm not saying that's not also maybe the case, but there could be avoidant behaviors that could be related to OCD. So it's just having that wider lens as a clinician of the why behind the behaviors. And I know that's not new information. We're always looking for the why. But over time, we have a lot of clients and there are folks who struggle with anxiety. I think the other thing is that many times someone who may be struggling with OCD is going to label it themselves as anxiety. And so then we'll be like, yeah, let's talk about, working on your anxiety. So remembering, is it just that? Is it OCD instead? Is it both? So that would be an example of the avoidant through a lens of OCD avoidance. And again, if you have questions, comments, please type that into the questions box. So reassurance seeking is a really interesting one, and I think is very, very specific in the way that clinicians can help or hinder this. So as you can see here, that repeatedly asking other people questions, and that can be including their therapist, their clinician, related to those obsessive thoughts, or compulsively internet searching to kind of, again, on the, say the medical example, if someone's afraid of a certain medical diagnosis or worried about that, it's like obsessively asking people, does it seem like this might be happening for me, or constantly internet searching. And it's that reassurance seeking, like I won't feel okay until the internet or this person promises me this, isn't the case. And a lot of times as clinicians, from that kind of, thought stopping, reality testing, CBT approach, we will meet them in the content level. And in some cases, that's helpful when it may be a cognitive distortion through anxiety, kind of reality testing some of that. It's actually not always super helpful with OCD because that's exactly what they're looking for to reduce that immediate feeling of anxiety. So great, I'm going to get the therapist to also promise me that I don't have this. And so being careful to notice if you are, reinforcing that. So for example, if they're saying, have a certain fear about a certain medical diagnosis and you want to try to alleviate their anxiety and say, I think obviously, again, talk to a doctor, but I really don't think that's what's going on, trying to reassure them. It's a very small percentage of the population, whoever has that, like all those, sometimes they're going to go home and be like, well, I Googled it and I found this one story of this one person, just this constant kind of compulsive checking. And so what I will say, and I think is always such a key component to kind of intervention around OCD, is meeting them on a process level. And so these are the times that the content level and meeting someone on that content level is not going to be as effective. So, and we'll talk about that a little bit later, but noticing how you're responding to certain fear patterns, thought patterns, and if they are looking to you for reassurance, taking the time to actually bring up the pattern of the reassurance seeking instead of just falling into reassuring them. So that mental piece, so mental rituals to attempt to reduce anxiety, and that I think in some ways can be compared to, if it was a physical ritual, like, and some people see it as having to do some physical thing to reduce anxiety. It's the same with certain thoughts. There is a level of rumination. So if that turns into obsessive rumination over a certain event or a certain future event or a fear of something happening. And then this last one on this slide goes back to that earlier slide around checking our own biases. So part of OCD can be for some people sort of compulsive mental images in their mind. They can be sometimes disturbing images or ideas playing out in their mind. And that again can oftentimes cause a lot of internalized shame of how can I be having these thoughts, let alone a willingness to share even with a clinician that they're having those thoughts. And so that again is that kind of covert compulsion that may take some time for someone to feel safe enough to share with you. So sometimes starting with, again, that psychoeducation, that's very common, starting with an assessment of, do you ever have anything like that? And, you can decide when and how much you're comfortable sharing, with me, the details of that. So giving people space to feel safe to share that. But these covert compulsions are, again, and someone had just typed into the chat, yeah, they can definitely be viewed as anxiety. And as we all know, and again, with differential diagnosis, of course, there's a Venn diagram of symptomology. So it's not about, okay, now all of these are only, it's being able to expand out of it's anxiety or depression. And I think sometimes that can become just kind of that like pipeline of sorts of therapists just being like, that looks like anxious behavior, that looks like depressive behavior. And especially again, with a lot of those symptoms that can seem or look like anxiety, gathering some of this information, kind of taking a look back, even on current clients, of what were some of the patterns of that? How did that show up? What are some of the behaviors that I'm seeing or their thought patterns? How have I been assessing that? How have I been responding to that? And again, I can't say enough how common that reassurance seeking piece can come in. And therapists, clinicians, and people's loved ones, more often than not, are providing that attempt at reassurance that's very well-meaning, and sort of using that attempt at logic of trying to reassure someone through logic. That's not what their brain is actually seeking. This is an OCD compulsive behavior. This is not a specific, question from a one-off kind of discussion where someone's using that logic objective brain. But as clinicians, we want to support people, reassure people. So really be mindful of that. Yeah, some questions on how to deal with if a client has violent mental images. First I would, again, always as clinicians, we all know in terms of being mandated reporters. And so some of that is, of course, starting off with gathering more information. Can you, tell me how long you've been experiencing those? Does it involve certain or specific people or more generalized? How do you feel when you're having those thoughts or those thoughts come up? Have you ever, as those thoughts have come up, considered acting on those thoughts? So gathering some of that information from them. And again, normalizing it. These are questions that I would, want to ask anyone to make sure I'm gathering all the information necessary to support you as best as possible. So if that person is saying, no, never in a million years would I even consider actually acting on that. I hate having these thoughts. I don't know why they're happening. I'm so distressed that they're even coming up. So that's where it can say, it's really hard to admit that. I'm glad that you did, because now we can talk about some strategies of what to do when those thoughts do come up. So really, meeting them where they're at, creating that safe space. Yeah, another question of difference between reassurance seeking and general need for reassurance that people need in our just in our kind of current world. Yeah, I think that some of this is if you see a pattern of behavior. So if you have a client who there's a kind of a pattern of needing reassurance around certain topics or thoughts, or in those conversations, kind of repeatedly needing you to tell them this isn't going to happen or this will be okay. As we think about cognitive distortions, sometimes that can come through of this very all or nothing thinking, like I need to know this won't happen, So, and we can't promise that, right? Not that we would in any case, whether someone was struggling with OCD or not, but being mindful of that. So I would say if it's a pattern of behavior around different topics, or if it's a pattern of behavior on the same topic over and over again. So kind of the short answer to that one would be if you're seeing that pattern happening. Yeah, and someone had shared that they referred someone to a medical provider who was able to find a medication that helped one of their clients with some of those mental images. I'm glad that you mentioned that. There is certainly, medication that is utilized for OCD, and please, always encourage folks, as we do with our clients, to find a psychiatrist or, a primary doctor who they trust to kind of have those conversations with, which is part of that holistic approach. Yeah, so for dual diagnosis, what considerations there are, and that can be, I think also what can help is when we are more accurately assessing what's going on, then we can figure out, okay, what are some strategies we can utilize to support some of these symptoms. And I'm going to talk a little bit here in a moment around kind of the somatic side of treatment that I think is very effective for a lot of different symptomologies and diagnoses. So I see that as a really helpful starting point. Someone may have OCD and anxiety, and I would definitely suggest a lot of the body work for both of those things. I'm also certified as a Reiki practitioner and a death doula. I think, a lot of this is around how we widen our lens. I've probably said that too many times already, around what treatment looks like. So, and I think with OCD, what's really interesting is determining whether, virtual or in-person classic talk therapy is going to be most effective for it. Because what we sometimes do, or what I see a lot with OCD symptomology is, and I'm already getting ahead of myself, there's a slide on this, so we'll probably get to that in a moment, is kind of, we're trying to use the same tactic that got us into the compulsive and obsessive thoughts to get ourselves out of it, and that's not going to work. And so as a talk therapist, sometimes it's like, okay, let's, thought stop, let's reality test, let's, talk it out. And in many cases, that's either going to be a neutral outcome or in some cases potentially make it worse. So I want to talk a little bit about some treatment here. Another quick reminder in terms of potentially kind of just noticing symptomology in session. Yeah, so, some folks were talking about if someone is concerned about kind of the status of the world or anxiety around politics, that's not going away. So if they continue bringing that up, yeah, I think it's also just noticing, have they ever had anything else, that there's a pattern that they are focused on over a long period of time? What types of questions are they asking? Does it feel like those are obsessive thoughts, or does it feel like those are coming from a more place of figuring out ways to cope? So yeah, there's going to be things that are long-term stressors in the world for many folks, and kind of how we see as a clinician what those coping skills or attempt at coping skills look like. And it could be also, like I'll show here in a moment, integrating some of those assessment tools for OCD. So some folks may be familiar with a term called stimming. So that is a shorthand word of self-stimulatory behaviors. As you can see here, oftentimes repetitive movements or sounds. And there are so many more resources out there. If anyone's ever seen like adult fidgets that people can use in meetings, or like fidget spinners for whether kiddos up to adults. If you go on any, if you Google that, you're going to see a million things that you could buy. And a lot of it is, again, for self-soothing. But in session, sometimes it's noticing, how am I potentially jumping to conclusions around what some of the external physiological behaviors are showing. And so a quick kind of further differential diagnosis as we talk about or look at autism and OCD stimming. So there's different motivation behind it, and then kind of what is it distressing or not? So as you can see here, that in OCD, that stimming is more fear driven, of like, I need to do this compulsive behavior. If I don't, then I will feel anxious or something bad will happen. With folks who have autism, that's really a self-soothing behavior. So, in kind of over more simplified terms, that distress is like, for folks struggling with OCD, some of those behaviors can be more distressing, or like this need to do them from a more kind of distressed place. And then otherwise, for folks who are doing it for more of a self-soothing. So that's where it can be, again, as clinicians, to check in with folks. So if you're noticing a behavior, if you're noticing a pattern, to have a conversation around that. How does it feel when you do that? How does it feel in your body? So really kind of evaluating and hearing from that person what that behavior is doing for them. So a few questions to ask. On the next slide, I'm going to show a screenshot of one of the pages of this Yale-Brown Obsessive Compulsive Scale. These are just a few. Again, as a clinician, it's determining, what would be appropriate for each client and their, what they're demonstrating in terms of symptomology. But do you feel out of control of your compulsions? Do you engage in any repetitive behaviors or thoughts? Again, a lot of times folks only see OCD as some external repetitive behavior, turning the light switch on a certain amount of times, or thoughts to prevent anxiety. Again, something like repetitive behavior can be reassurance seeking, or constantly Googling every single medical symptom, but checking every single page 15 times. These are repetitive behaviors to prevent anxiety that are not actually helping us. How often are you having these thoughts? So the Yale-Brown Obsessive Compulsive Scale is a very common one. This, again, for anyone who may have joined a little bit later, this entire slide deck is available to you to download through the handouts. So that is a direct link to access the entire Yale-Brown Obsessive Compulsive Scale. So the first 3 pages are a series of questions with a Likert scale answer, scale of 1 to 5, how often or how severe certain symptoms. And then the last page is here. I know it's a lot, but I wanted to at least kind of, again, I'm not expecting anyone to read every single thing on here, but this is a screenshot of the last page of that OCD, Yale-Brown OCD scale. And you can see here, I wanted to show it just so you could see some examples. And so, you know, are you experiencing any of these currently? Have you experienced them in the past? And you'll see some of that under that miscellaneous obsessions down at the bottom. Again, you know, almost, yeah, there's asking about a child scale available. It's a good question. I have a resources slide at the end of this slide deck that has, and one of those links is for the International OCD Foundation, and it has just so many resources, and I guarantee they're going to have an entire section on child and adolescent resources and assessment tools. So I'm glad that you asked about that. But wanted to, you know, kind of provide some examples of this. And this is where it's, you know, for many folks, they maybe have a tough time admitting they're having some of these thoughts or worries or fears. And so dispelling a lot of that stigma around OCD symptoms and educating folks on this can be really helpful for that. So wanted to, again, provide that visual of what that one page from that longer assessment tool looks like. I know there's a lot on that screen. All right, so I talked a little bit about kind of OCD treatment and is CBT effective or not. You know, that's a very short question to a more complex answer because every individual's treatment plan is different. I would simply say, and I know I've said this already, is to be very thoughtful about CBT interventions with OCD. Yeah, someone had said they looks like they found the child adolescent version of the Yale-Brown scale. Great, awesome. So again, thinking our way out of obsessions or waiting until we get reassurance or helping someone, you know, or reality testing, all of that can sometimes create more of that just obsessive cyclical thoughts. And so this is where a more holistic approach to OCD is really, really helpful. So there is exposure and response prevention. One of the links on the resources slides I have is a link to a ton more information around ERP and resources available for that. There is mindfulness-based stress reduction, or MBSR, under that mindfulness therapy that is an evidence-based tool. I'm going to talk a little bit more on the next slide specifically about more of kind of that body work. Motivational interviewing, I think a lot of us are familiar with that. But sometimes what we'll hear from folks who may have certain compulsions with OCD is, but if I don't have OCD anymore, I won't be as clean, you know, and there could be some ambivalence or uncertainty around what changing the behavior is going to look like. And I think as clinicians, we're familiar with that. You know, our bodies and our brains are very built on habit. It's distressing to change habits. And then on top of that, if we're working with someone who struggles with OCD, those habits and behavior are even more kind of ingrained in terms of, without these, I will have debilitating anxiety. And so having some space to really work with someone on, you know, not only educating them about what it is, and then getting to the point of, you know, what are some of the pros and cons you've experienced from that? What do you think would be different in your life if you didn't have OCD anymore? What do you see as, do you have fears about that? What is your goal, or what would you want it to look like? So some of those motivational interviewing questions can help kind of normalize that ambivalence for some folks, give them space to talk about it more readily. And I think in general, as we know, is an effective tool for most clinical intervention to join with people. I love motivational interviewing, but specific to some OCD behaviors, it's, I think, a really important piece that is easy to get missed. And I think some of this is also the psychoeducation, that thinking isn't going to fix our thinking, you know? So like, how do we flip the script? Because again, a lot of times, and this is where there's crossover with anxiety and OCD, is I'm just going to fix this by thinking more about it, right? And so normalizing that that's one of the most common reactions and responses and beliefs we have, and then spending some time explaining as to like why that's not actually the case. So there's a couple of reasons that if I think my way out of this, I can just fix it, happens. One is that sometimes we truly believe that. It's like, okay, I just talk about it, I think about it, and then I, can figure out how to fix this. I'm not saying that's an ideal verb to use, but kind of how clients might be feeling. The other thing is that, as we all know, many people don't want to feel their feelings. They don't want to drop into their body. So there's a sense of, well, I could just fix it with my head and never have to feel what I'm feeling. And so both are kind of sometimes working against that initial or ongoing kind of experience of somatic experiencing. And so as a clinician, if you are someone who provides talk therapy or specializes in CBT, it could be where you expand some of the treatment modalities if someone is, meeting criteria or you're noticing OCD symptoms, or it could be with OCD specifically, standard, just straight CBT talk therapy isn't always necessarily going to be fully helpful. Here are some additional resources because somatic experiencing is a critical component. So that's where, as a clinician, it's being willing to notice and give verbal space to, here's the process I'm seeing. Because as we know, clients are going to try to bring us back into the content all the time. And either because the process is too uncomfortable or they don't even know what's happening. And so, really speaking to, what does it feel like in your body right now as you say that? What does it feel in your body right now as you don't practice that compulsion when you want to? So with somatic experiencing, that is, how do I even notice my physical body sensations? And with OCD, a lot of this is, I'm practicing these rituals so I don't have uncomfortable sensations. And we all know that's, of course, avoidance of feelings is not unique just to OCD, but it's critical in terms of healing. So I think being able to work with people on any attempt at a solution being, I just won't feel anxiety, is not ever going to work. And so how can we sit with uncomfortable feelings and doing that in a safe, contained space? So I would say that any OCD treatment needs to include somatic experiencing mindfulness aspects so people can actually sit with and know how it feels and sit with, basically, if we want to talk about, DBT, like distress tolerance. And that's the same piece if someone is working with someone through that exposure and response prevention. The way that's going to work is if people are learning how to sit with the anxiety of not doing that pattern or compulsion or having that thought or not, seeking reassurance about something. It is going to bring up anxiety. And that's where I think a lot of the psychoed can come in, is practicing changing behaviors or adjusting is going to feel anxiety inducing at first. It is going to feel like it's going against everything your brain wants to do, So try to, as a clinician, not get caught up in the content and always bring it back to the process in these patterns, check in with people on how they're feeling. And then again, I think this is a really helpful breakdown of how do I pay attention to and give voice to my body sensations. Some people are more of, visual learners. Have them draw what it feels like in their body, if that's easier. I think sometimes we so often try to use language to explain or express everything, and it might not be the type of expression that works best for someone. So can they draw it? Can they, describe it in a more abstract way? And then, what am I feeling when I'm thinking this? Continuing to practice that. And then determining what type of mindfulness techniques, what type of relaxation techniques work for me. And I've had many clients, and I'm sure many of you have as well, who will say, someone always tells me to try this coping skill and it doesn't work for me. It's like, yeah, that's normal, So some people's coping skills work great for them, and for someone else, it doesn't really, vibe. And so a lot of that is what works for me. What do I find that's helpful? And especially, again, I know this is common with a lot of treatment, but with OCD is thinking, what can you do in the moment it's happening? So what are immediate regulatory practices you can try, whether that's certain breathing techniques. And I always encourage, instead of telling someone, just take some breaths, teach them a specific breathing technique. Square breathing, 4-7-8 breathing, alternate nostril breathing, something that is more tangible. So, I've had one person say that they always carried sour candy with them because if they had a uptick in anxiety, they would eat a sour candy that would kind of shock their system out of it. What is something that could resonate with them that is going to help them know they have the skill set and practice and availability to regulate their feelings in the moment. And then, of course, on top of that, providing them with resources for guided imagery that sometimes helps people sleep. So different relaxation strategies, all of that. So again, that holistic approach and that body work is so critical. So with the resources slide, that first link there is that International OCD Foundation I'd mentioned earlier has a wealth of information, is a wonderful place to find all sorts of resources. And then that McLean Hospital, that has a lot, much more, way more robust. There wasn't time to get into it today, but a much more robust outline of that ERP treatment, what that looks like, things to try, more articles about that, more resources about that. And then the guest house is actually a like inpatient treatment program that I found, but I found this link that talks specifically around that somatic experiencing and how that really helps with OCD. That previous slide is, kind of a snippet from that site. But they also have, if you go to that link, have a whole panel of other articles, resources specific to OCD and treatments that can be helpful, ways to intervene in a way that's more holistic. So I really appreciated their approach and those resources for it. And so I think, really what I see as what I thought was most kind of motivating for me and what I really wanted the main kind of takeaways to be is making sure you're assessing for OCD, because again, it sometimes gets lumped into anxiety inadvertently. Be aware of any assumptions or triggers in terms of what people may be sharing with you if they're having intrusive thoughts, and how to respond to those in a way that you are, again, meeting them with that unconditional positive regard and support, and that it's really around those somatic distress tolerance skills, and thinking in many cases for OCD, standard talk therapy may not be as holistic of an approach as this person may need. It doesn't mean that can't be part of it, but it could be encouraging them to also look into more of those somatic type treatment modalities. It can also be, of course, always helpful to recommend maybe like a debrief or a group therapy group that focuses on that, having that normalization from other people, seeing other people's experiences. I think in general is really kind of sometimes an underutilized resource for folks, and they can get that kind of peer support. So that's another thing to consider. Of course, all of this is going to be based on, making sure they talk to their physician, but something like acupuncture, yoga, a lot of different very wonderful holistic approaches that can be helpful for people to feel, really feel safe in their body. And I think for clinicians, on just about any reason someone's coming in, that's such a core piece of healing. And so even kind of explaining that when talking to people about the goal for treatment and kind of getting out of that content world that we can all get stuck in. Okay. Yeah, so some folks are saying that, they have also used, looks like IFS. Someone wants I might have to have someone tell me what their, okay, yes, thank you. Internal family systems, yes. So that is wonderful, and I'm seeing, suggestions of what has helped other people. It looks like there is, like I said, that resource for a child adolescent assessment scale. Yeah, so someone had some questions around kind of something like, using a sour candy. What that's doing is when we get very escalated, or our body's in kind of that fight, flight, freeze mode, it's kind of in that physical fight, flight, freeze. And something like a sour candy is going to bring our logic brain back online and kind of get us out of that fight, flight, freeze, because one of the 5 symptoms kind of had this shock to the system. And so what it's allowing us to do in that moment is get out of the fight, flight, freeze and actually back into our body from a more balanced state. So we can, from a more balanced perspective, understand and feel our feelings. Let's see. Let's see here. Yeah, so someone had also, we've got a lot of stuff coming through here, so I apologize if I missed something. Yes, holding an ice cube can really help people. Same idea as a sour candy. Let's see here. Yeah, so quick reminder about how to get the CEU. So what we're gonna do is Canopy in the next few days is gonna post a recording of this up on our website. If you go to canopywell.com and you just go to the providers, you'll see the CEUs. And then once you're on there, then you can watch it, and you don't have to watch it all again if you've already seen it, but you can click on it and there's a very brief, it's usually 3-question quiz. And if you take that quiz and pass it, it's usually, it's pretty basic questions about the content. And then it'll automatically send you a certificate. Okay. All right. Well, I think we are, let's see here. Yeah, someone was talking about it helped for one of their clients. They kind of helped them externalize the OCD as that kind of, and I don't want to speak too much for you, but kind of that separate thing, that it's happening at certain times. And sometimes by doing that externalization of it, to be able to monitor it from a more kind of once removed place. Yeah, that's a great suggestion. Yeah, someone's asking about payment. So the CEU, taking the quiz and getting the certificate is free if you are a provider who is on Canopy's panel as a provider. If you're not on Canopy's panel, then it's $25, but it is free. And you can access and find all the archived webinars if you are on Canopy's provider panel immediately through the provider portal, and you can log in and find it that way. Good question. Okay. Well, I think what we will do, I may have, oh, yeah, we already made it there. If you do, have anything come up in terms of questions, obviously reach out to us. Probably the easiest way, if you go to canopywell.com and you click on providers, there's ways that you can access Canopy if you have questions. You'll see more information about the CEU webinars. So that's a good place to start. Or if you're on our panel, you can log into the provider portal and get a lot of information there, or be able to email the provider relations team if you have questions about that. So hopefully, I think it was just kind of an overview, good thing to remember. Educating ourselves, always good. So I appreciate everyone's participation and questions and comments. And thank you so much for attending today. Have a good rest of your day.